Alan Wikler. You're there in New York, Alan?
Yes.
And that's morning time, right?
It's yes, it's still morning. It's not noon yet.
Yeah, and that's normally what happens with me. It's dinner time for me, and it's breakfast time for my guest speaker in America. Of course, y'all have got various timings. You got the mountain time, you got the day saving time. So I'm used to all that. So nice of you, Alan Wikler, to have said yes, and you come on my show. Yes, I know there were a couple of delays due to certain unavoidable conditions that I had to undergo some surgical thing, but I'm perfectly fine thanks to all the blessings and the prayers from all my friends like you. You are on the 52nd episode of Dr. M's Vodcast. Can you see my screen?
Yes.
So there we go. You are on the 52nd episode. So thank you very much. And this is series
well, thank
one.
you for inviting me. I appreciate being a part of this series.
Well, thank you very much. I started the series of supporting and sustaining continuous improvement processes because that was somewhere around when the pandemic hit all of us, and I thought, let me globetrot and use this as a media to understand what's happening globally. And today, I'm really lucky that I'm going to listen from you how a clinical psychologist's passion that got you into lean and your lean black Six Sigma expert, and that too in healthcare. So I'm very curious. So I am now going to introduce you to you. So I'll leave that part of it to you. And this is what I do. I have been for the last nearly 2 years, got guests across the globe speaking about supporting and sustaining continuous improvement across America, Europe, India, South Korea, Japan, Australia, Canada, and Jamaica. And you're also going to talk about the same thing, about supporting and sustaining continuous improvement. And you have said all what you have learned, lessons that you have learned from the healthcare is absolutely fascinating. And this is my signature. So Alan, you're on Dr. M's Vodcast, and as you heard, my only mission is to connect continuous improvement professionals across the world, share I learn from them and share it back to the continuous improvement community. I want to hear you. I'm very curious to know what you're going to talk to us about, especially in the healthcare sector. That's going to be absolutely amazing. So, go ahead. You can share your screen, and I'm going to just close my eyes and ears, and not my ears, my eyes, and just listen to you. Yeah, you're perfect.
Thank you, Dr. M. And as you mentioned, I am a clinical psychologist in New York. I'm retired now, but I've had quite a journey from starting out, here in America, we start in college, and by the end of your second year, you would have to pick a major, and I picked psychology. And I want to talk about how I ended up in psychology and what I did, and how that took me through a bit of a twisting serpentine path to being a lean practitioner, which is why I've got the picture of the path going up the mountain, as you see. So my first decision after college was that I was interested in social psychology, about how the awareness and presence of other people, people in a group, influence behavior of one person. And I found years later that that was important when practicing lean, working in a team and trying to help and influence the team. I then got interested in clinical psychology, about treating mental illness, because I have a desire to help people. And I did that and earned a degree called, not a PhD, but a Psy.D, which is a doctor of psychology, which I earned in 1985, quite a while ago. So after getting licensed, I worked in clinics and hospitals and private practice, and I got to do some research. One of my earliest jobs was working with the New York State Psychiatric Institute, which is obviously a state research institute, and it's staffed by faculty of Columbia University. And at that time, they were working on what was new at that point was the Diagnostic and Statistical Manual, or DSM, as some of your viewers may be familiar with. It was new at that point, and it was very rigorous. Basically, it really tightened up how people get diagnosed with a mental illness based on signs and symptoms common to a group of people, which then guides treatment. And that was a very good experience. After some other jobs, I ended up working in the New York, or actually it's part of the National Veterans Affairs system. Veterans Health Administration is a set of hospitals and clinics that serve the health needs of veterans, people who have been in the military and left the military in the United States. And I wound up working in an institution called the New York Harbor Healthcare System, which operates on 3 campuses in New York City. And initially, I worked as a clinician, and I was working primarily in the substance abuse program. And when I got there, it was a very different experience than I had working at the Psychiatric Institute. Things were a bit looser. What I was working on for Columbia was diagnosing people based on specific criteria, and the VA at that point had not adopted that. And then the Veterans Hospital, as all hospitals, or just about all hospitals in the U.S. do, they're accredited by the Joint Commission, which has their own set of standards that are published, and we're supposed to live up to them. To be honest, in that year, many years ago, we didn't do so well on that accreditation site visit. And the chief of mental health asked the staff if there's anybody interested in doing performance improvement work. And having had that experience at the Psychiatric Institute and noticing the difference between the way they worked and the way we were working at the VA hospital, I raised my hand and I started working in the mental health service doing performance improvement. And initially I was still seeing my patients, but the work got very involved, and I ended up doing performance improvement in mental health full-time. Then shortly after that, a job opening came up for the hospital in general, hospital-wide medical, surgical, as well as mental health, as the Deputy Performance Improvement Manager. And I applied for and got that job. And so now I'd made the transition to performance improvement, quality assurance, and quality control. And I did that as the Deputy Performance Improvement Manager. I was also the acting patient safety manager for a time, so I got interested in patient safety as well. And then in 2011, the group of VA hospitals in my area, including my hospital, got interested in how they could do better, how they saw that other hospitals were more effective in achieving their goals and in meeting their improvement and performance metrics. And they sent out people to different high-performing hospitals in the United States. The person who was going to do it for my hospital was my boss, the performance improvement manager, who was unable to go and asked if I would go. And the hospital that they chose for me, some of your viewers might have heard of, is the ThedaCare healthcare system, which is in a small town in Wisconsin. And this was the middle of the winter. I flew out there, changed planes to a tiny little plane, and landed in Appleton, Wisconsin. Very skeptical of the whole thing, thinking, what is a small hospital in Wisconsin going to be able to teach me? What could I learn from them coming from New York City, maybe being a little bit cocky about it? But I saw what they were doing at ThedaCare, which I didn't realize it was recognized as one of the earliest and at that time furthest along on their lean journey. And the tour and the explanation of what lean, the Toyota production system, was all about was given by John Toussaint, who used to be their CEO. He became the executive chairman of Catalysis, which some of your viewers are familiar with, which does consultation to people who want to improve healthcare in their systems, with an emphasis on leadership development. And I saw what they were doing in their hospitals. They actually did construction on a wing of a hospital that was based on lean principles, and they had visual controls built in to the very construction of the building. I saw their outpatient clinic, which everybody that I spoke to was able to explain what they were doing based on lean principles. And they told me what their results they were getting. And the whole experience for me, I can only describe it as an epiphany. This was something that was really of interest to me. And I said, this is what I want to do. I want to bring this back to my hospital and be a lean practitioner. And it turned out that the other people who had gone to other high-performing hospitals, Virginia Mason in Seattle was one of them, and there were a few others. The people that went there told similar stories, and they said, we have to do this. And so the group of hospitals were dedicated to making that change and starting their lean journey. So that's another journey that was started. So it was a personal journey, and it was a journey for the hospitals in the veterans healthcare system in the New York, northern New Jersey area. And so they went about getting training for staff in Lean, in the Toyota production system, and Lean Six Sigma. And we created a system redesign team within performance management, which for my hospital in New York City, I was ahead of that. And I did that for many years. I've practiced and facilitated hundreds of various types of performance improvement projects, rapid performance improvement events, lean projects, minor, quote, just do it type of performance improvement by frontline staff. And I've seen a lot and I learned a lot and I've got a lot to share, which I think will be of interest to your viewers. And I did retire this past December after being at that VA hospital for 31 years. And since that time, I've been studying, getting to read the books that I didn't get a chance to read about lean while I was practicing it. I've been doing writing, blogging, discussing, and consulting in lean healthcare. So that's how I got to lean. So consistent with the title of your series, I've titled this talk today, Supporting and Sustaining Continuous Improvement, Some Lessons Learned from Healthcare. I'm going to share what I learned from doing all these projects, facilitating them, from the things that went right, but also probably more importantly from the things that didn't work as it relates to sustaining improvement over time. And you and I talked about this briefly another time, Dr. M, this series, which I like a lot. I've seen some of the other videos, Supporting and Sustaining Continuous Improvement. The words themselves are a bit of an oxymoron. Yes, we believe in sustainment. After we do improvement, we want to make sure that the improvements we made are sticking, that it's not eroding back to where it was. But yet, it's in the context of doing continuous improvement. So we don't want to stay in the same place forever. We believe in continuous improvement. So what does it mean to sustain in the context of continuous improvement? To me, it's sort of that after you've worked on maximizing the efficiency and the outcome of a process, you want to make sure that it continues to perform at a measurably and significantly higher level for a period of time. It's sort of a plateau is the best way to describe it. And then you go on from there to improve even further. It's sort of like steps. You go up, you stay at that level for a while till you're sure that the improvements are sticking, and then you start the improvement process some more and you go up higher and higher, which is the way I see it. When we do improvement or continuous improvement or Kaizen, as it's commonly called, at the end of the project, we like to standardize the new change, and we usually do that with a document which we call a standard work document, which I know most of your viewers are familiar with. And when we explain what a standard work document is, and this will be covered later on in my talk as well, we have a process and we're doing it a new way. It represents the best way we know of doing the process at that time. It doesn't mean that it's going to stay that way forever. The expectation is this is the best we know how to do it now, but we're going to keep trying to improve it continuously. So even when you're at sustainment, or you've been able to sustain a change, you're always looking towards how can we improve it further. And we're always looking for those opportunities of how can we make this better. So turning to healthcare, what does this mean in healthcare? Well, we try and improve processes that bog down the process for the patient and for the staff. We look to reduce delays for the patient and for the staff. There's a lot of waste in healthcare, as there is in every process, and there's a lot of defects, and so we want to eliminate the defects. The thing that I think is most important are the defects where in healthcare, the patient gets injured or the patient dies. I think a lot of people are aware of the publication, I believe it was 1999, called The Error is Human, in which they found that healthcare being very risky and being a very complex process often results in unintended injuries in the process of it. And so we want to try to reduce or completely eliminate, if we could, what we call iatrogenic injuries, meaning injuries caused by the healing process or the treatment process, or just being in the healthcare environment. This includes actual injuries, infections, and other harm from the healthcare process. Very frequently, patients in the hospital fall, and those falls could be serious. There are post-surgical infections we are all aware of. And there are other types of infections that people get in the course of being treated. They get catheter-associated bloodstream infections. They get pressure injuries just from being in bed. You don't have to fall out of the bed to be injured. You're in the bed, and if you stay in the same position too long, putting pressure on sensitive areas, you develop pressure injuries or bed sores. And these are things we don't want. And in most cases, these things are avoidable. Thinking about post-surgical infections, when somebody goes for surgery, they tell you about it on a phone call, or they post it on social media. What does everybody say to them? Unfortunately, what people say when they mean well is good luck. Having a good outcome and not having a complication like a post-surgical infection should not be a matter of luck. That tells us where we unfortunately still are in the process. And so that is a very, to me, a very important thing to target in terms of performance improvement in healthcare. And the things that we're trying to do is, as I said, we're trying to reduce the incidence of these hospital-acquired infections and other injuries, but we're trying to eliminate them. So what does sustainment mean? Well, sustainment in this context means that a team, a work group in the hospital, maybe in surgery perhaps, or infection control, or the nurses working at the bedside want to reduce infections or pressure injuries, and they will do performance improvement, and they'll measure it with a metric that we like to call the key metric, the one measure that really reflects have we improved the process or not? It would be a rate of infections based on the volume, or a rate of pressure injuries or bed sores. And some hospitals have been able to reduce it completely to zero for a period of time. They'll say for this month or a few months, we have had no pressure injuries, or we've had no post-surgical infections. And that may last for weeks or months. But really our objective is to get rid of it completely. And we would like to see sustainment. The ultimate goal is 0 defects. And we want to see that for, if they've done it for 3 months, we want to see it for 6 months or a year or longer. And hospitals are working on this, and hospitals are succeeding, and they're doing better. So, so to talk about sustaining improvement, in this talk, I'm going to be looking at the performance improvement project, the different steps in doing it, and how sustaining improvement is a matter of practicing it well at every step of the process of Kaizen, whether you're practicing Lean, Lean A3, Lean Six Sigma, or doing just PDSA cycles. There are things in every step where it has an effect on sustainment. Even at the very beginning, even before you start the project, there are things that you need to do, or you're not going to be able to sustain the improvement. If you're able to improve the process, it's not going to be sustained if you start off wrong. Okay. In healthcare, patient gets admitted to the hospital. There's a saying that discharge planning, the last step of the process, begins on admission, the first step of the process. And the same is true for doing performance improvement. Okay, you start working on sustainment just when you're setting out on that project. The first thing that you really have to do is make sure that everybody is buying into this, that the people who are involved in the process, and the process owners and other stakeholders, want to do this, that they don't feel it's being forced on them. Because you can do that. You can do that kind of top down, you're going to do this. And you may get some positive results for a while, but it's not going to sustain. And so the first step really is what some people call change management. Change management is making sure that everybody understands what it is we're trying to do, why we're trying to do it, and what's in it for each person in the process, and what role each person has. And that, if you want to get sustainment, that's something that you can't overlook. It's got to be a part of the performance improvement process, doing change management. Before you start a new project, typically people will write a charter. Where are we going? That's why I'm showing the compass in the picture. Where are we going? Okay, because if you're off by just a little bit when you're starting a voyage, by the time you get to the end, you're going to be way off course, and you're not going to be able to sustain it. You need a charter that has a reasonable scope. Okay, if you try and do too little, or more often, too much, you're not going to reach your goal, or you're not going to sustain it. An example from healthcare is there's a great need desire to cut down the length of stay, how long a patient stays in the hospital, is of interest to every hospital that I know. And doing that and making that the target of your Kaizen is not going to work out because it's too broad. Too broad. I mean, it's too complex. The journey for the patient starts on admission. They come from typically through the emergency room, which is a whole process in itself, and the decisions made to admit them to a floor bed. And once they're there, they go through many processes of diagnosis and testing and consults and such, all of which in themselves could be performance improvement projects. They go through that, they're diagnosed, they're treated, and then you start the discharge process, and that's extremely complex. And that's a whole separate process to look at in itself. So if you're trying to focus, your scope is on input, throughput, and output, as we call it, that's going to be too broad. It's going to be like trying to boil the ocean. If you know that expression, I know that your viewers are all around the world. Trying to boil the ocean, or the other expression we use is for too big a scope, is that you're trying to achieve world peace. Hopefully world peace is something we can accomplish, but it's a very big scope, and my experience is that we're able to reach our goals and sustain them better when we have a more closely defined and manageable scope in the charter. You also need good data. What I tell people when I'm facilitating lean is that something that they don't want to hear, which is that you constantly have to collect data. You collect data throughout the project. You need baseline data of how the process is performing before you do anything. And so you may need to collect data before you do anything. Have that baseline data all through the improvement project. You're collecting data. You may come up with root causes and countermeasures that you want to test. When you do the countermeasures, the data becomes very important because you want to see, are you moving the needle? Are you making a change for the better or not? Or are things getting worse? And you need to collect data even after you're done with the so-called project. I don't even like saying the word project, because what we're doing, like I said before, is continuous improvement. And so I give them this bad news up front that you're constantly going to be creating and collecting data from this moment on. If you're lucky, it's data that's readily available, things that are time-stamped in the electronic medical record, like the time that surgery began, something that you can also often find, but in the computer. But there's some things that are not time-stamped and have to be collected by hand. Like when people go to an outpatient clinic, okay, the typical process is patient arrives, and you'll see all the waste in the process. Patient arrives and they wait online to check in. And then they check in with an administrative person, and they're told to have a seat. They have a seat in the waiting room. And by the way, just reminds me that when I visited Theta Care, Dr. Toussaint showed me their new lean outpatient clinic. It didn't have a waiting room. And he said, don't you think that's strange? We don't have a waiting room. He said, well, we think it's strange to have a waiting room because all of waiting is muda or waste. So why spend money on waste. And they managed to improve the process such that they were able to eliminate wait time. Anyway, getting to my story. So they've checked in, they're sitting, they're waiting anxiously to be called by the doctor. And then they hear their name called. They follow somebody into a room. A medical assistant does their vital signs, tells them to take off their clothes, and then they're told to wait again until the doctor comes in. Okay. So you see, there's a lot of waste in that process, waiting online to check in, waiting again to see the nurse, waiting to see the doctor, which is really what they're paying their money for. That's what has value for them. Now, if you're going to do a project like that, you're not going to find a lot of data in the electronic medical record. A lot of that, you may have the check-in time. You may have a doctor's note, but you don't know when the doctor wrote it. So a lot of that data has to be collected by hand. Somebody has to stand there with a stopwatch, or now it's built into the cell phone, collecting data on how long did the patient wait until they saw the clerk? How long did they wait until they saw the nurse, etc. And so you need to have data that's reliable. And if the data is not reliable, you're not going to have good outcome or sustainment. And so sometimes you need to train people on how to use the data, how to collect it, and how to interpret it, using control charts and process behavior charts, which we'll go over later. And the third thing that happens at the beginning of a project is that the team goes to where the process is happening, something that we call going to the Gemba. And having some people call it a Gemba walk, or some people call it go see, has a big place in Lean. It's should be a part of management's responsibility to go to the areas that they have oversight and responsibility for. For the purpose of this talk, I'm talking about the Gemba walk that is a part of performance improvement. If you're going to improve a process, you can't, even if you work in it, you can't assume that you know it. You have to go over it. You have to watch, observe, ask questions, okay? Be honest about what you're doing, so that you come away with a thorough understanding of the process. And when I say thorough, I mean thorough. That sometimes the smallest step in a process is going to be the rate limiting step, and you might not even know it. That's why I've got the picture of our friend Sherlock Holmes there with his magnifying glass, because you have to look very carefully. There's a saying we use in America, I think a lot of people use it around the world, that the devil is in the details. Sometimes it's the same, right? I guess they're familiar with it, Dr. M. The devil is in the details. That the smallest detail, something you could easily overlook, could be what's holding you back. And that I remember a particular team that was working on something. It was a process of reducing the turnaround time for consults from a specialty service. And the team wrote down all the steps because they were going to flow map the process. And they talked about how a consult is generated, and the consult prints out. Secretary takes the consult printout to the chief of the service. The chief of the service looks at it, goes into the medical record, and so forth. But what they left out and only saw once they actually walked through the process was that these consults that went through the medical record and printed out on a printer, which was not near the secretary. And as a result, the secretary didn't take the consult as it's printing out and pick it up and run and take it to the service chief. And other papers are being printed out to that printer. Maybe it was some instructions for the patient to give to the patient. The doctors were printing out. So it wasn't a dedicated printer. And so the secretary was observed that they would either pick it up at the end of the day, thus a whole day was wasted before the next step happened. We call this lead time, okay? If you're doing a value stream analysis, or sometimes maybe she would say, oh, I see there's a bunch of papers in the printer. Before I go to lunch, let me take that and bring it into the doctor. So it was being done once or twice a day. And that caused significant delays in the process. And so there's an example there of what I mean by the devil is in the details. Okay. The other thing is that people often assume they know the process because they're in it. And when they're doing process improvement and they're working with people who's like someone like me who is facilitating from performance management, sometimes they don't tell you they actually process it. They tell you what they think the process is, like they did in the one I just told you, or sometimes they give you the process the way it should be. And I call that the three processes, although I don't think I made that up. The three processes are what you think the process is, what the process should be, and the third, the one we care about, is what the actual process is. Okay. So in the actual case, with the consult turnaround time, what we observed was that there was batching going on. And that was not one piece flow as we've learned through the Toyota production system, right? And that was causing delays. So again, these things, if they're not done right and carefully, in this case, having a thorough understanding of the Gemba, you may not get the improvement that you want, and it may not be sustained because there's details of the process that haven't been addressed. One of the main reasons for a process improvement not being sustained at the end of the project was that the wrong root cause was addressed. They didn't get to the right root cause. And this gets to, well, how is the root cause being determined? There are two approaches to this. Sometimes they're combined. One is called making a fishbone diagram, or the proper name, the Ishikawa diagram. That looks like the one you see pictured here. And the other one is asking why 5 times, known as the 5 why process. This may be a prejudice, but from my experience, I found the 5 whys is better, and that there are some major drawbacks to using the fishbone diagram process. Again, you want to get to the right root cause, because if you don't get to the right root cause, it's not going to be sustained. Okay, so what are my objections to the fishbone diagram process? Well, as you see, there are major bones, as you might call them, that you're looking at. In this example, it's measurement, materials. Some people call it man or personnel. environmental reasons, methods or process, and machines. And typically, people will brainstorm, think of, well, okay, personnel, what kind of things could be happening? In terms of materials, what kind of things could be happening to cause the defect that we're trying to get rid of or reduce? And my objection, there's two objections I have to that. Number one, the categories are predetermined. There's no reason for that. Okay, if you've gone to the Gemba, if you walk through the Gemba, if you emerge with a full understanding of the Gemba, you've seen things, you've seen what the process is, and almost always, in my experience, you've seen the waste, you've seen the bottlenecks, you've seen how the defects are created, or the risks where they could be created. The example I just gave about the batching of the papers, okay? And so there should be no reason for you to be brainstorming. It should be based on facts, things you've seen, things that your team has observed, and data that you have as well. And so that's my major objection. Some people do a very superficial fishbone diagram. They'll address the major bones, and they may dig a little bit beyond that. But what you're going to get is superficial. You may get the immediate or proximal causes. To me, you don't get to the root causes unless you dig really deep and use the 5 why methodology. So in the 5 whys, we know what that is. It's very simple. Even a child could do it. And I say that because people have said, it's like, you're like, if you do it the right way, you come off sounding like a 5-year-old. Somebody says something and you ask why, and they give you an answer. And then you say, well, but why? Again. And you get another answer. And again, you ask why? Okay. Sounds silly, maybe sounds juvenile, but you're getting deeper and deeper each time. And it's called the 5 whys, but there's nothing magical about the number 5. Sometimes you get to the root cause, an actionable root cause, before you get to 5. Sometimes it's more than 5. And when you get there, you'll know when you're at the root cause, because the root cause will have an obvious countermeasure. And it works because you're using actual knowledge. No brainstorming is needed or should be used. The example that I like to use when I do training is a nurse who administers the wrong medication. There was a nurse who gave a wrong medication. The team interviewed her and asked her, why did you give the wrong medication? Do you have any ideas why that happened? And the nurse says, well, I don't know. All I remember, I was very tired that day. Okay, so now you've got your proximal cause, fatigue. Is it actionable? Not really. What are you going to do? Okay, well, the problem is our nurses are tired, so we're going to ask them to drink some coffee every 2 hours. Okay, it's not a great solution because it's not the root cause. You need to be curious and ask again, well, you were tired. Any particular reason why you were tired? And the nurse says, well, I worked a double shift that day. So now you're still curious. Well, any particular reason why you worked a double shift? And the nurse says, yeah, there used to be 2 of us RNs working in this area, but one of them left years ago. and was never replaced. Never replaced. So the obvious next question is why? Why was the nurse never replaced? And the nurse says, well, I was told that it was posted and we got candidates, but they ended up not taking the job. Why do they not take the job? Well, we weren't offering a salary that was competitive with the other hospitals in the area. Now we're in a territory that's far away from where we began. We're just not about fatigue. The problem really here is about offering competitive salary. And again, like I said, when you get the right root cause, the solution is obvious. Okay. If we offer competitive salary, we'll get another nurse. We'll have two nurses, so the nurse doesn't have to work a double shift, and the nurse won't be fatigued, and is less likely to make a medication error. I love the 5 why methodology. I learned about it, I think, in around 2001, 2012 when I started. I was reading the New York Times, as I do every day. And in the March 10th, 2016 edition of the New York Times was an article called How Asking 5 Questions Allowed Me to Eat Dinner with My Kids. And I ended up reading it, and lo and behold, it was all about the Toyota production system and how it's been used in industries to improve efficiency and profits and safety in American industry. I'm not sure if they mentioned healthcare specifically, but I read it, and they go on to describe a problem that they were having personally, which is that they weren't able to eat dinner with their kids. And they showed in the article how they used the 5 whys, trying to solve the problem. Why do we never manage to have dinner with the whole family? So you ask why, and the answer was because my wife and I always got home later than expected. You ask why again? Well, we were doing tasks that we ignored all day, so we're getting home late. We weren't going to morning meetings, and there are things that we didn't do because we were late to work. So why had we ignored those tasks? We were arriving at work right before our first meetings because we were leaving the house later than we planned. Why were we leaving the house later than planned? It took so long for the kids to get dressed in the morning. Why did it take so long for the kids to get dressed in the morning? And they thought about that a lot, and they said, well, they're very picky about their clothes, and a lot's going on in the morning. We're trying to have breakfast and get dressed, and we're dressing ourselves. And really what they should be doing is choosing their clothes the night before. And so the root cause being that they're taking so long to choose their clothes in the morning, their solution was laying out their clothes the night before. So you get very far from the proximal cause when you get to the root cause. And if you don't address the right root cause, it's not going to be sustainable. When you get to the right root cause, the countermeasure or solution is a perfect match. It fits like a lock and key, like I've got pictured here. Okay, it's a perfect match. Okay, going back to the nurse, you're not paying competitive salary. You don't have to brainstorm solutions, which is what a lot of people do. They say, okay, we know what the root cause is, but let's think up what we're going to do. Well, if you do it right, you don't have to think up what the solution is going to be. It fits it like a lock and key. We've got to offer a competitive salary. Okay. So once you come up with your solution or your countermeasure I don't call it a solution at this point because you haven't tested it. You don't know a solution. You know, you have a countermeasure to a root cause. That's the important thing. And so you do your testing. You use a method that some people call PDCA, plan, do, check, and act. Some people call it PDSA, plan, do, study, act. Some people don't use the word act. They say adapt or change. So doing this is very important. It's a key, okay, thing to do, that you've got to do the PDSA or PDCA the right way. You have to design it. One thing I found from facilitating this is that if you have a very complex new process, you write a document that's like, or maybe even is a standard work document. It's not a standard work document per se because you don't know it's the right or the best way to get results known at the moment, but it's sort of a script, like you're doing a play where everybody's part in the play has to be known, written out, scripted, and rehearsed. They have to be trained on it. They have to practice it. Because what I found is sometimes people said, oh, we're going to do this test of change. And it didn't work. And the reason it didn't work was because they didn't do the new process the way it was designed. So one recommendation I have from my work in healthcare is to write out the process, especially if it is complex, okay? And you have to do training on it. You have to collect data after you've done the do part, where you put it into effect and given it some time so that you have multiple data points to collect. You have to have multiple data points. One change in a control chart doesn't mean things are better or worse. You have to look for trends. My colleague, Mark Graben, who is an author, wrote several books on lean, wrote a book called Measures of Success, and he talks about being able to detect a signal that's meaningful and interpretable versus noise, which is not anything that you need to interpret. It's just noise in the system because you don't have enough data points or you're not seeing a correct trend. You have to have a certain number of data points going up, or in this case, going down. Most of the time, process behavior charts, as he likes to call them, or control charts, as some people call them, or more people call them, or were not interpreted correctly. They didn't have enough data points. Most of the time, you want to see, you know, most business charts, you want to see things going up because it's profits going up, perhaps, okay, or number of customers going up. In lean, we're trying to reduce most of the time because we're trying to reduce defects and we're trying to reduce waste. So here's an example of a process that got better because it went down. And you see that there were, I believe these data points are every other month. This is 2 years of sustainment at a higher level, at a better level, less defects, less waste. And so doing the PDSA, it has to be done correctly, designed the right way, training on metrics, interpretation of the control charts. Another important thing I found is having qualitative data, okay? It's not just, is the process better, but asking people involved in the process, how do you feel about the process? And one time that a process, I'm going to kind of talk around what the project was because it's a little bit sensitive, and I work for the U.S. government. So I'll just suffice it to say that we did a project having to do with improving the discharge process, and things were better during the test, during the PDSA, but was not sustained at all. And we saw that in the data. And from talking to the people in the process, we learned that the staff was not engaged. They weren't on board. They said, well, this new process involves an extra responsibility that we're too busy to do. We feel rushed. We don't think it's something that we can do. And they didn't really go along with it. Unless you ask those questions, look for the qualitative data. How do people feel about the process? Another thing that you might want to look at is balancing measures. Let's say you are doing a project that influences length of stay, even though I think length of stay itself is too broad a thing to tackle. But you're successful in that patients are leaving the hospital faster. Well, it begs the question, well, were they really cured? Were they really ready to leave when they left? And the only way to answer that is to look at another measure, in this case, their readmission rate. And so you look at those two things together. Okay, so yes, maybe we were successful, we got them out of the hospital faster, but we see that the rate of readmission went up. That's telling you maybe it's not a great process. Okay, so I suggest balancing measures. Okay, and getting back to PDSA or PDCA, a lot of people, Mark Rabin being one of them, he likes to use the word adjust rather than act, okay? In that performance improvement is continuous, and when you get results, you want to maximize it. Sometimes you need to tweak it a little bit, and then run the PDSA or PDCA again and again till you optimize the process. Okay, maybe you change the new process, as I mentioned in the other project, where it doesn't overburden staff. Overburden being another thing that Lean and the Toyota production system sees as a problem. You don't that's not respectful for people. And so you redesign it again, you adjust. And these things will, again, then you ask the question, oh yeah, we're fine with the new process. You're going to get better sustainment because you've got the buy-in. And this is my last slide, but by no means is it the least important. This is about standard work. As I said before, standard work is the best known way of doing a process. It gets the best outcome measurably and hopefully significantly. Okay? And you write up the process. You include step by step what people do in the new process according to what their role is, what the steps are, who does it, the sub-steps, frequency. Ideally, you might have a picture in here so you have a visual control as well of what the process looks like. Once you do that, like I talked about during the PDSA, you should do some training, make sure everybody's on board, practicing it as if you're doing a play. and you might want to test if it's working. You're collecting data. Okay. If you're collecting, some people do what they call audit of standard work. They just do that as a standard operating process. That once the standard work goes into effect, you have a supervisor look to see, is everybody doing what they're supposed to do according to standard work. Other people, and this worked for the groups that I facilitated, only did it if the data wasn't holding up. Okay, if you are looking at the data and you saw improvement and it's sustaining over time, you've reached that plateau we talked about in the beginning, fine. But if you see erosion, okay, meaning the metrics going back to the way they were in the baseline, you're not sustaining, the first thing you have to suspect is, well, people may not be adhering to the standard work. Maybe there's new employees who weren't trained on it. And so you do an audit at that time. Are people adhering to standard work? And if need be, you do retraining. A simple retraining is sometimes all that's needed to get you back on track if you're starting to lose your sustainment. Again, I said this in the beginning, the process owner has to be on board. They're responsible for making sure the data is collected and that the new process is maintained long enough to show that it works. Like I said in the beginning, it's just a plateau. You're going to want to see if you can make it even better. I've got a picture here of the Egyptian pyramids as an example of sustainment. I'm told they're estimated to be about 5,000 years old and they're still standing, but they're not perfect. They may be eroding a little bit, but they're still there. I don't know if we can improve on the pyramids, but in healthcare, as well as any other industry, we want to sustain what we do, but we want to see always, can we do this just a little bit better? And in healthcare, that might mean, can we sustain it for a longer period of time? Can we get down to zero harm, which is one of our goals, one of our most important goals? Can we eliminate wait time? Can we eliminate waiting altogether? Can we reduce turnaround time? And can we do it better and better? So I'm going to stop there. And if you have any comments or questions, I'd be glad to address them. But again, thank you for giving me the opportunity to talk about what I've been doing for a long time and sharing what I've learned from healthcare in terms of continuous improvement and sustainment.
And that is such a lovely flow that I listen to you, and you can stop sharing. We can just have a 2 minute chat. There's no question because your flow was extremely good, in a subject of healthcare. First of all, let me compliment you on the smooth flow, and you touched a lot of critical points. And the other thing that fascinated me, since you are a psychologist, and which really one of the posts that you put up was you wanted. I have it here because I remember you saying that improvement projects or lean transformation. How were success and failures defined? Okay, that was one of the posts that you had put up, and I laughed over it. I did not comment on that because you had just hit the the nail on the head. Is because if you're talking about lean And these days I say it lean TPS. I suffix it by TPS because there are different shades of lean. And as a matter of fact, Mark Garvin gave you the right answer for that too. And I remember that Mark Garvin's answer, which you questioned, that was again very interesting. That it it really attracted because I always believed that there is no start line or end line for lean, and there are ups and downs. But if you are convinced that things work, you have seen things work, and if it works, you know that it can work because you have seen it work. Lovely example where you don't require a waiting room. This examples which really hits the core. I like your example of why don't we have dinner together? Uh, that was another example that really we think that it is just within the factory compound that we have to do continuous improvement and respect for people. I have been always a advocate that if it doesn't start with your home, where does it start with? It's an excellent flow, and I really appreciate you questioning that. And Mark Garvin's answer, I know what he answered, and that's factually true. So thank you very much, Alan, to have taken your morning off, and rest be assured that this is not like continuous improvements. It's not a project that is going to end. I'm going to have you more often with certain deeper questions because I would like to dig a slightly deeper into healthcare.